Hi, SVU. Sarah Schonsberg here. I'm coming to you live from Oregon Vascular Specialists in Bend, Oregon. And I'm going to show you a standing reflex evaluation. And I'm going to be using a cuff inflator for that. So I'm going to kind of show you some of the setup for that, as well as show you some of my examination techniques and discuss a little bit of our ergonomics. Of course, this demonstration, if you've ever been to a SVU conference before, or even any vascular meeting, this demonstration is happening over video, and that's a little different for us because of COVID and the way that we've all changed our lives. So you're gonna have to bear with us a little bit. I'm obviously masked, my patient is masked, so you may not hear as well as you can, but I'm just gonna do the best to project my voice. And as well as when I turn around from you, because of kind of the double whammy of being away from the camera and having a mask on, I'm going to turn around to talk to you. So I'm not going to talk a lot when I'm turned around demonstrating something. So just a little bit of a caveat on how it's a little different this year. So let's start by kind of showing you some of the equipment. And I'm just going to turn my camera here so that you can see. So I have a Hokinson cuff inflator set up. And the Hokinson cuff inflator is a automatic cuff inflation system. And there are other cuff inflation systems out there. Hokinson just happens to be the one that we use at our lab. And what we do is we have several different cuffs. So this is a 10 centimeter cuff. And this is one that I would use for calf inflation, and I'll show you that and demonstrate where I would put that on my patient. I also have a smaller cuff here. Let me grab that. This is a transmetatarsal cuff. It's a 7 centimeter cuff, and it comes with an attachment that can connect it to your cuff inflation system. These are really great if you have a patient with ulceration at the ankle that you can't wrap a calf or an ankle cuff around, so that you're not squeezing around an ulcer, and you can actually get a transmetatarsal augmentation with this. I really like it for some of my really thin patients too. I can wrap it at the ankle where it tapers and maybe get a little bit of a better augmentation than I did with the calf cuff. And sometimes you're just going to play with those placements on different patients, obviously, because everyone has different anatomy. So the last cuff that we have is a thigh cuff here, and this is a tapered thigh cuff. Sorry, this is kind of a big cuff to hold up. And so it has two different Velcro straps, which is really nice. This is a 17 centimeter cuff, and the Velcro straps are independent of each other. So I have two straps that I can taper, and I can put those on the thigh so that it tapers down and doesn't slip down the thigh as I'm trying to do my distal augmentation. I also have two different types of switches for doing my distal augmentation. I have a timer here, and this one it has like a nice long cord on it so that I can wrap it and place it next to my patient. And what happens is when I push the switch here, it automatically holds my augmentation for 3 seconds and then lets go. So we know that we have to hold that distal augmentation to elicit reflux. We also have a foot switch here. That one is not plugged in right now. I like to use my timer, and I'll show you why, but the foot switch can be plugged in and actually can be placed underneath your foot so that you're not reaching for that button all the time and just using your foot to push down on the foot pedal and elicit that distal augmentation. The thing that's a little bit different with a foot switch is that you have to turn on the augmentation and then wait 3 seconds for it to hold and then turn it off again with your foot. It's not timed like the little timer button is. So that's a little bit of the difference there. Right now, my Hokinson is set to 99 millimeters of mercury. I just changed it to 100 because that's probably the lowest amount of pressure that I want to use, depending on patient pain, or if they can't take the pressure, I might turn it down a little bit. But 100 millimeters of mercury is kind of what I want to start with for a calf augmentation. I can go up to 120 millimeters of mercury, but usually I go with 100 the whole time because I can get a nice distal augmentation with that. when I get my distal augmentation, I want to see that 30 centimeters a second forward flow, because we know that that's what's adequate to actually close the valve and create that adequate transvalvular pressure gradient so that we're closing that valve. So sometimes we're going to have to turn this up a little bit. Sometimes we're going to turn it down a little bit. But you notice that you have your pressure control, and 100 is just where I like to start. So let me show you a little bit about my setup ergonomically and just my patient setup with my cuff. I'm going to move my cuff back over here. So you might notice that I'm sitting pretty low to the ground now, and it's a little difficult to see on camera, but I am using a small footstool, and I can show that to you. Put my probe back there. So my footstool looks like this. So it's just kind of a normal footstool that I would get at any convenience store. And it's a nice stool that's low enough to the ground that I don't have to twist and bend to get to my patient's calf level. So right now I have my patient sitting up on the table. I've raised my table so that it's quite high. And I'm just going to move this forward a little bit. And underneath her feet here, I have a box, and this box is about, I'd say, a foot high, so that it's getting her off the ground higher than me. Go ahead and stand for me. And so now you can see that when I'm going to be doing my exam, I'm not going to be doing a lot of twisting and bending, because I'm moving my footstool really close to the stand that she's standing on. And when I'm twisting, I'm just going to twist my body so that you can see exactly how that's done. And my probe is not going to be real far away from my body. I can have her even take a step forward towards me so that I'm even reducing that abduction of my shoulder. So my shoulder is not moving as much. So I want to avoid that pressure as I go up. When you do these tests, sometimes it's really nice to have a stool that changes height for you, so that if I do need to come up here, I can actually move my stool up so that I can have that less abduction with my arm, so less than 90 degrees with my arm, and I can bring that down and reduce my shoulder strain. You'll also notice, I'll move back a little bit, that my ultrasound machine has been lowered and that my screen has been moved to the side. So my screen has been moved to the side so that I'm going to have a straight on view of my screen. I'm not going to be moving my neck too much up or down or side to side, so that I don't have a lot of neck strain with that. And then my keyboard is low so that I'm not lifting my key hand too high either, so that I'm not injuring my shoulders at all. So let's go ahead and put some cuffs on and show you some placement on the lower extremity. Today we're going to be scanning a right lower extremity, and I'm going to show you the calf cuff first. So the calf cuff, I like to put right on the meat of the gastric venous muscle. So where that calf muscle is enlarged, and I'm going to get a really good augmentation from that because I'm squeezing on that muscle. So I'm squeezing those gastric venous and those sural veins, sending all that blood up the leg to look for valvular incompetence. I'm going to plug in my cuff to my air source, and then I would be ready to augment. So let's say if I want to do a thigh cuff on this patient, I have a couple choices. So if I have a thigh cuff and I have a thin patient and I want to move this cuff up, I can, because it takes up less residence on the leg. So it takes up less space on the leg. But if I have either a larger patient, or if I have less area that I need to examine in thigh, like say I just want to do the saphenofemoral junction or the anterior accessory, then I'm going to use my thigh cuff. And let me just grab this here. And our patient is a little small for this, but I'm going to show you how you would put this on. And see how it's tapered. So it's tapered so that it will hug the thigh like this. And when I examine the groin up high here, then I would get a really nice distal augmentation. For this cuff, it has 2 outflow hoses, so I want to make sure that I'm taking my little plug out of my hose and plugging both in when I do that augmentation. All right, go ahead and have a seat. And then the last cuff that we have is the transmetatarsal cuff. That's this little one with a long tube. I'm going to wrap this on the arch of the foot. So if our patient had ulceration or veins that we wanted to examine right on the distal end of the ankle, we could use the transmetatarsal cuff, and we plug the same hose in and get our distal augmentation from that transmetatarsal cuff there. As far as standing reflux goes, I want to talk a little bit about vasovagal and some of the concerns that people have when standing patients up. So when standing a patient for a venous reflux test, a lot of people will get nervous about their patient passing out, will get nervous about this kind of autonomic response that happens with that distal augmentation. And what I always tell people is that what you want to do is set yourself up for success. So we have our bed nice and high so that if our patient needs to take a break, that bed is always there for them to sit down and take a break. I also like to have a really dynamic test. So in between the thigh and the calf, I like to give my patient a break. So I'll say, okay, I'm going to move the cuff now. So I'm going to have you take a break. And I would be moving the cuff from the calf down lower onto the ankle a little bit. Let them sit down, let their blood pressure regain. Then you can start augmenting again once they stand again. For the small saphenous vein, we're also going to have them move a little bit. That seems to help as well. And then just checking in with your patient. So just make sure that you're looking up at them. Are they starting to sway a little bit? Are they saying that they're hot or feeling a little nauseous? Then of course you want to sit your patient down, take a good break with them, let them even lay down, get them a glass of water, things like that. But I also think that one of the things we need to realize is as we're doing these exams masked now, a lot of patients end up having a little bit more hyperventilation from being in a mask. So they're already nervous from being there. They already are kind of in this heightened state, and maybe their blood pressure is changing from that, as well as having a mask on. And once you put that cuff on, you start augmenting, they can get a little bit dizzy. So I always warn them of that, and I tell them to communicate with me if they're feeling dizzy, and I tell them to take breaks whenever they need them, and they don't have to tell me. So just a few little safety tips. And I think that it's going to be different for everybody. Just make sure that you're checking in with your patient and make sure that they're comfortable communicating with you and that you're paying attention to what's going on there. And I should show you Gretchen's varicose vein. So I'm going to have you come forward just a touch. And let's have you twist this leg a little bit. Thank you. Okay, so I'm going to bring my camera in just a little bit here. And I think it's a little difficult to see with our lighting in here, but she has a varicosity that's right here, kind of popping out on this calf, kind of in the distribution of the great saphenous vein. And when I do my exams initially, I'm going to examine the leg with the patient in the standing position. I'm going to turn them all around, look at every surface of the leg, and I'm going to kind of palpate in that great saphenous area looking for varicosities. And as I do that, I can see an additional varicosity on this medial thigh here. And then you can see it come down, and it actually wraps around onto the posterior calf as well. So you want to make sure that you're evaluating that small saphenous as well as that great saphenous all the way through. Of course, this is just an initial evaluation when we're just looking physically at the leg and kind of guessing where these things might come from. But when we have our ultrasound, we want to make sure that we're going up and down the leg, checking all of the accessory veins in the thigh so that we don't miss any connections they might have. I'm going to push you back a little bit. And let's put this calf cuff on. And we're going to plug it in. I'm going to use my self timer here. So I'm just going to set my self timer down right next to me on the box so that it's really easy for me to hit. Okay, and so right now I'm using a hockey stick probe because our patient's pretty thin. So because our patient's thin and because she has superficial veins, I'm going to use this hockey stick probe, which can go up to about 13 to 14 megahertz. What you also can use is a linear probe. This is a 12.3, so it goes all the way to 12 megahertz. And this can be used to look at the deep venous system as well as the superficial venous system. And for some of your larger patients, you might want to end up with the linear probe or even the curvilinear probe, which is this one. And this is the C5-1, so it goes from 1 megahertz to 5 megahertz. And sometimes you're going to use these for larger thighs so that you can see a little bit deeper and just get that resolution that you're looking for. All right, so I'm going to take my superficial probe here. I'm going to have you turn your foot out just slightly. Perfect. Thank you. And with just a little bit of gel here, I'll scoot right up to my patient so that I don't abduct my arm too much. And then I'm going to scan on the great saphenous vein and look for a reflux. I'll do a distal augmentation with my timer that I've placed just right next to me. So I'm just going to stop and lean back a little bit. I know that it might be difficult to see. Pull you forward just a touch. So I can see a great saphenous vein within the saphenous fascia here and transverse. I can also see varicosities that are superficial to the surface of the skin, right in the area of that saphenous vein. So I turn my spectral Doppler on in longitudinal, and I'm going to augment. And that held for 3 seconds. So our image right now, hang on 1 second, is inverted. So I went ahead and inverted that image so that you could see our distal augmentation. And you can see the distal augmentation on the screen just here. And then when we released that distal augmentation, you can see reflux in the great saphenous vein just beyond that. Let's take a look a little bit more. Okay, so what we notice in this image here, as we're coming down the thigh a little bit and we're further down this thigh, what we see is the distal augmentation here, and then we actually see valve closure. And I don't know if you heard that or not, but this is a competent vein, so the valve closed right away. And the reason for that is that when we look at this thigh and we actually evaluate the great saphenous vein, we can see the varicosity come off at the mid-thigh. So at the mid-thigh, we had a little bit of reflux right at that varicose vein, but then as that varicose vein comes off, it's siphoning all that reflux down the thigh and into the proximal calf where we saw that varicosity before. So what I'm going to do, I'm going to move my cuff down so that I can examine that varicose vein down on the calf. So I've moved my cuff lower on the ankle, and what we're going to do is try our distal augmentation there. I still have my pressure set to 100. If we need to turn that up because we're not getting a good enough distal augmentation, we can do that. But we'll evaluate once we've done one augmentation. So let's take a look just surrounding this varicose vein here. Okay, so there we could see a good amount of reflux. So you probably heard it in the video, but you can see our distal augmentation just here on the screen. And as I cine, I can see the reflux throughout this whole segment. And if I am doing a clinical exam, I'm going to measure that reflux with calipers because we know that reverse flow greater than 0.5 seconds is considered significant reflux. So we want to measure that so that we actually have a time to put in our report so that we make sure that we're actually measuring significant reflux within that vein. So this is reflux within the great saphenous vein again. So if you'll remember, as we were in the thigh, we had reflux up above, right by the mid segment, and then we had normal flow in the great saphenous around the knee, and then now we're refluxing again in the great saphenous and the proximal calf. So what I would do at this point is look for why am I getting reflux in just these segments. So we know that the reflux exists above the varicose vein in the thigh, and then we know that the reflux exists just above the varicose vein in the calf. So now I want to see why that is. How are you doing? Are you doing okay? Okay, good. So we're just checking in with our patient, making sure she's doing okay with our augmentation. And now I'm going to go up and I'm going to look to see if I have any varicose veins from this mid-thigh coming down and rejoining this great saphenous vein, creating that incompetence there, which results in the ability for that other varicose vein to come off of that saphenous vein there. So I'm going to take a quick look with the ultrasound. Okay, so I found my point. So you can see the large vein in the center of the screen is the saphenous vein, and then there's a small vein coming off to the side there, entering the fascia at that point. And that's a varicose vein that's coming from the medial thigh and rejoining that great saphenous vein at about the knee. So then we have our reflux, we have our varicose vein, we have reflux again in the great saphenous vein that comes down to feed these varicosities in the great saphenous on the medial calf. So if I have had my patient turn around, so now I have a really nice view of the distal calf, the posterior distal calf, and I can look at the small saphenous vein here. I'm going to move my cuff up slightly so that I can evaluate that small saphenous. I just want to make sure that I'm getting a good augment here. So because that small saphenous is within this gastrocnemius muscle, I want to make sure that my cuff is up slightly so that I squeeze on this gastrocnemius muscle and I'm not too far down in the ankle and I don't get a good enough augment there. I'm going to plug it back in here. And I still have my timer next to me. Using our superficial probe again. So we can see a large small saphenous vein in the center of the screen here. And what I want to do when I'm looking at small saphenous veins and small saphenous reflux is I want to evaluate for a saphenopopliteal junction. So your saphenopopliteal junction can be pretty much anywhere in this area. So it can be a few centimeters up the popliteal crease. So even though it's not right at the popliteal crease, it's still considered a saphenopopliteal junction. The reason for finding that junction is that if a physician decides to do an ablation treatment to this vein, we want to know if there's any risk for that ablation having an E-hit or an extension of the thrombus into the popliteal system. Let's go ahead and check this small saphenous for reflux. So I'm turning in longitudinal. Okay, great. So even though this vein is dilated in this segment that we saw, it's actually competent. So we can see our augmentation just here, and then our 3-second hold, and then on our release, we only see the small blip of valve closure, and we don't actually see any reversal of flow. So this tells me that that small saphenous vein is most likely compensating for some of the reflux in that leg, and it's actually acting as a drain. So it's one of the exit points for this extra blood that's built up from that incompetent great saphenous vein going into that small saphenous and re-entering the deep circulation. So after I've checked my great saphenous and its accessory veins, so an anterior accessory or posterior accessory, I can also check the small saphenous vein. And then what I want to do is look at the lower extremity and see if there are any varicose veins that I have not sourced yet. So I just look physically on the back of the leg. I can palpate on the back of the leg, and I can palpate on the calf and look for any more varicosities that I haven't seen before. We look good on the posterior side. I'm going to have you turn around for me again. Thank you. And then we saw where these medial ones came from. So the veins that we were evaluating for today, we sourced. And then we looked on the lateral side and on the shin and didn't see anything extra. So at this point, I will have ruled out a DVT for my patient in the supine position. So before my patient actually was in the standing position, I would have ruled out DVT. Then I would have done my deep venous reflux. So I wrap my cuff around the calf and I look at the common femoral, the femoral, and the popliteal system. I evaluate the superficial system as we just did. And then I'm going to make sure that I have a source for all my varicose veins. So I'm going to make sure that I know for where any of the visible veins on the lower extremity to me or the patient. Sometimes I ask my patient, are there any veins that I didn't scan today that are bothering you, or show me the veins that bother you the most, so that I make sure that I have a explanation for those. And then I am pretty much finished with my exam as long as I have a source and an explanation. If you're looking for more, if you're looking for more resources about venous reflux testing, you can go onto the Society for Vascular Ultrasound homepage, and they actually have professional performance guidelines for venous reflux testing, as well as the American Vein and Lymphatic Society. You can find some great information there, and the IAC, or the Intersocietal Commission. So that is our accreditation body, and you can look for more information there. All right, well, thank you very much for watching our little demonstration today and bearing with this change that we're all going through. I hope that you felt like you got a little bit of our hands-on session or live session that we typically do in the conference. Thank you so much. Bye, SVU.